welcome everyone, and thank you for taking your time to watch our recording on the very important topic of understanding the difference between high cholesterol and familial hypercholesterolemia. I'd like to introduce you, first of all, to our three panelists. We have Professor Mafalda Bourbon, who's a senior researcher in genetic dyslipidemias with a special focus on familial hypercholesterolemia. And she's based at the National Institute of Health and also the University of Lisbon. Joining us as well, we have Dr. Simon Pfisterer. He's a principal investigator at the University of Helsinki and the co-founder and chief scientific officer for Monsite Limited. And then we also have Elsie, who is part of the FHEF Foundation team, and she is our Education Lead and Ambassador Programme Manager. So on that note, I would like to hand over to Mafalda to begin.
Thanks, Emma. So I was asked just to try to speak about understanding the differences between high cholesterol and familial hypercholesterolemia. So this is what happens if you have familial hypercholesterolemia or FH. So when you're born, you already have a very high cholesterol. And that cholesterol starts building up in your arteries, like the way you can see here. With age, starts building up a plaque. That's what we call to this cholesterol accumulated in the artery. And if you're not treated, by the age of between 30 and 50, you very probably will have a heart attack. But if you are treated, that figure can completely change. So if you are identified and treated in early childhood, you can actually prevent the plaque to grow. But if you are identified late and treated late, you can always get some reduction of the plaque. And it, depending on the age that you start a treatment, you can go even to almost having no plaque at all. But if you have high cholesterol due to lifestyles, and we call it usually environmental dyslipidemia, you start off when you're a baby with a normal value of cholesterol. And what happens is, like, due to your lifestyles, you start your values of cholesterol start increasing during your life. So let's say that is usually around 30 that your cholesterol levels start to increase because you change your lifestyles, you're working, you have you're more sedentary, you don't take care of your diet so much, and then so your cholesterol starts to building up, but slowly, as you can see here. But if you continue to with your lifestyles, not good lifestyles, you continue to build up cholesterol, and you end up having a plaque as well in your arteries, until it's completely blocked and the blood doesn't flow, and you have a heart attack as well. So high LDL, if it's not treated, it can, or most will happen, is that you have a heart attack. It's just the difference between FH and not having FH is, like, in FH, it will happen much sooner because your cholesterol levels are much higher and you start having high cholesterol since you're born. And we actually have scientific data to corroborate this that I've just said. So in 2016, Kara, a researcher from the United States, did this big study that proved that persons with the same LDL with FH and without FH have a different probability of developing coronary heart disease. That's a kind of cardiovascular disease. And it shows that FH persons have a 3 to 4 times greater risk of having a coronary heart disease. So this is much higher risk for people with FH compared to another person with the same value of LDL. You can see here in blue is the risk of someone without FH, and in red, the risk of someone with FH. But we have good news. So we can identify who has FH. So there's clinical criteria to identify FH patients, and we have genetic tests that allows for the confirmation of that clinical diagnosis. And how do we do this in the lab? So the first step is that the doctor has to diagnose you with a clinical diagnosis of FH, and then asks for a genetic test. So you go to a lab, there's some blood that is drawn from you, and at the lab we extract your DNA. After we have your DNA, we need to sequence the DNA. And this means that we're going to amplify from your DNA the part of the genes that are involved in lipid metabolism and the ones that are related to the FH, so the LDL receptor, the ApoB and PCSK9 genes. And also we can amplify other genes in lipid metabolism at the same time. So this is the new way of doing genetic diagnosis. We can study many genes at the same time. After we amplify your DNA to study the genes that we want, we have to analyze that data. It's a time-consuming and sometimes complicated part of analyzing all the data. But when we analyze and we have the variants that we think that they can be cause of disease, we're going to confirm by another kind of sequencing called Sanger sequence, that we just sequence the fragment where the variant is, and then we have to classify that variant. And the classification of that variant is very important. We have some guidelines from the American College of Medical Genetics and Genomics, and we can classify those variants, and I'll talk about that just in a minute. But when we have a variant that we know it's a causative variant, we then study the family, and it's very important that we study the whole family, all that want to be studied, because it's very important to be identified early if you have FH. So like I was saying, that the most important part is the variant classification, and the variant classification is going to give us the interpretation of the clinical significance of each variant found. And you have here also the genes that we included in our panel. So the 3 FH genes, LDL receptor, ApoB, PCSK9, and then the 5 genes related to other lipid disorders that sometimes can resemble FH phenotype. So the guidelines, the American College of Medical Genetics and Genomics has, since 2015, published a general guideline that you can see here. This general guideline we use for classify ApoB and PCSK9 variants. We have in 2022 published as well a guideline only for the LDL receptor variant classification. So this is an improvement from the general and very specific for the LDL receptor. And what is the result of this classification? The result of this classification is that we have 5 classifications, or the variants pathogenic, likely pathogenic, there is a variant of uncertain significance, likely benign, or benign. And this means that if it's pathogenic or likely pathogenic, it confirms the clinical diagnosis. These classifications are considerable actionable classifications, so the doctor can use the genetic test to improve and optimize the patient treatment. And usually we only report pathogenic and likely pathogenic in the genetic report. We don't report the other kind of variants. In some cases, we are sometimes we report variants of uncertain significance, because it's really important to see if that variant of unknown significance that we call VUS co-segregates in the family with a hypercholesterolemia. This meaning that if the persons in the family that have high cholesterol have the variant, and the persons in the family that don't have high cholesterol do not have the variant, that is called co-segregation of the variant. That's the study that we do. And sometimes, if we are able to study enough family members, we can upgrade the variant to likely pathogenic with this classification grid, or downgrade to likely benign. Now, of course, if we grade to likely pathogenic, it means that you really have FH, so you have definitive FH. But if the variant becomes likely benign, that means that that variant is not the cause of your high cholesterol, and the doctor needs to keep looking for what's the reason of your high cholesterol. So it's very important that you do genetic testing. The genetic testing allows for the correct identification of affected individuals and allows to differentiate a genetic hypercholesterolemia from an environmental hypercholesterolemia. Sometimes for the doctor, it's very easy to see if you have environmental hypercholesterolemia. But in the majority of the cases, it's quite difficult. If the doctor knows you at 40 or 50 years, it's very difficult for the doctor to know if you have high cholesterol since you are a baby or not. Maybe you have never had cholesterol checks. So it's only the genetic testing can allow this differentiation. And what is that going to make if you do a genetic test? That will allow for early personalized treatment, as early as possible, as I said before, and that will lead to a better prognosis for the patient. But the genetic testing also allows for cascade screening within the family. That means studying the whole family, and that will allow to identify very early some members of the family that they can be identified in treatment. And this way, they will never have developed cardiovascular diseases if they are treated since they are 8 years old. And of course, that leads for a better prognosis as well. And if you do the genetic testing, that also gives you determine the type of variant that you have. And with the type of variant, knowing the type of variant that you have, the doctor can optimize your treatment, and that will lead you to a better prognosis as well. And actually what the genetic testing does is that it will prevent you and your family, your relatives, to have cardiovascular diseases if you're identified early and treated early. Now, Simon will explain better how genetic variants affect disease progression. Over to you, Simon.
I will talk about how genetic variants affect disease progression. And I am Simon Pfisterer. I have a research group at University of Helsinki where we look at how familial hypercholesterolemia gene variants affect cellular processes and disease progression. At the same time, I'm co-founder and Chief Scientific Officer of Monsight, where we look at how biological variability between, for example, you and me, contribute to different treatment outcomes for cholesterol-lowering medication. I would like to start with introducing the topic that our body is built of billions of cells. And these cells organize in, for example, organs like the liver, muscle tissue, our heart. And this is a kind of specialization of the cells for certain processes that they carry out. The cells that are depicted here in the center, the information for them and the building plan for them is stored in the DNA. Here I depicted a cell and cellular processes that are highly relevant for familial hypercholesterolemia. How cells are taking up cholesterol. They take up cholesterol in the form of low-density lipoprotein, which are the yellow balls that you can see here. And they are taken up into the cells by a protein that is called LDL receptor that sits on the surface of the cells, binds to the LDL particles, and brings them inside the cells, and thereby reduces the blood cholesterol concentration. LDL particles transport cholesterol. So you can see an LDL particle here on the left-hand side, and it's the main carrier for cholesterol in our blood. And what I try to depict here is that these particles are transported in our bloodstream, and they reach peripheral tissues or the liver. And these particles and these peripheral tissues contain cells. And these cells, as I showed before, contain the LDL receptors that bind to the LDL particles and internalize those LDL particles. So this is a way of packaging the cholesterol, transporting it in the blood, and delivering it to the destination. And FH genes are directly related to these processes. What I show here are the 3 key FH genes where genetic variants really affect disease progression. It's the low-density lipoprotein receptor, LDL receptor, here that sits on the surface of the cell and internalizes LDL particles. It's genetic variants in PCSK9. PCSK9 itself can lead to degradation of the LDL receptor and thereby reduce the level of cholesterol that the cells can take up. Other mutations or genetic variants are found in apolipoprotein B. It's a protein component of the LDL particle, and which is needed that the LDL particle is recognized by the LDL receptor for internalization. So genetic variants in these 3 genes can give rise to familial hypercholesterolemia. And these genetic variants actually have an effect at the cellular level by reducing cellular cholesterol uptake. And I'm depicting here 3 scenarios. One is a genetic variant in the LDL receptor, which changes its morphology so that it cannot recognize anymore an LDL particle. Therefore, the LDL particles stay outside of the cell because they cannot bind to the receptor and they cannot be internalized. And this means that the cells cannot take up cholesterol, and more cholesterol stays in the circulation, in the bloodstream, and leads to increased LDL-C, which is measured in a clinical setting. Mutations in apolipoprotein B can have very similar effects. If the morphology of this particle is altered by a genetic variant in ApoB, again, it can lead to the effect that it cannot bind to the receptor, even though the receptor would in principle be fully functional, but the particle just can't bind to the receptor, and therefore it cannot enter the cells. For PCSK9, the situation is slightly different, as it affects how much of the LDL receptor is available on the cell surface. PCSK9 genetic variants can lead to enhanced degradation of the LDL receptor, so less of the receptor is available on the surface and more particles will stay on the outside and therefore stay more in the bloodstream and lead to increased LDL cholesterol. Whilst there are different genetic variants in these 3 genes, I think it's very important to highlight that these different gene variants, even in the same gene, can lead to very different effects at the cellular level. Whilst we have here the kind of, let's say, normal situation where the cell has normal levels of LDL receptor, can bind to LDL particles, and LDL particles are internalized, leading to low levels of blood cholesterol. A genetic variant can either change the morphology of the receptor, what I just showed, and the particle cannot bind, but there can be also other situations where a genetic variant leads to the loss of production of the receptor. So there is no more LDL receptor produced within the cell. There is no more LDL receptor at the surface, and therefore you cannot internalize LDL particles, and you have high blood LDL cholesterol concentration. There are also other variants that just not block or inactivate the receptor completely. They might just reduce how much of the LDL receptor is available on the cell surface, and thereby the process is only partially impaired, and you can still internalize LDL particles, but not to the same extent as a person living without a genetic variant. And this is relevant for the drug efficacy. So statins, via blocking cholesterol synthesis, actually increase the amount of LDL receptors on the surface of the cell, and thereby increase the intake of LDL particles into the cell, and thereby reduce blood LDL cholesterol concentration. However, in familial hypercholesterolemia, in a person living with a genetic variant that reduces the amount of LDL receptor that are on the surface, statins can only increase the LDL receptor to a certain extent and not to the same level as in a person without such a genetic variant. And therefore, the drug efficacy is lower. And in most cases, this means that a person living with such a genetic variant would need a combination therapy, for example, with ezetimibe or PCSK9 inhibitor. And with this, I would like to hand over for the final presentation to Mafalda.
Okay, so what does having a pathogenic variant means to someone with FH? So let's see. The first thing is that if you have a pathogenic variant, that means that you have FH. So for sure, you have definitive FH, and there's no doubt that you really have FH. And that can have different implications at a personal level. For example, if you really know that you have FH, it means that you have a genetic form of hypercholesterolemia. So you do not have high cholesterol due to your lifestyles. Sometimes this is really important for a person with FH to know this, because they know they have high cholesterol. They do everything. They change the diet, they change the lifestyles, and their cholesterol still remains high. And some people actually feel guilty. What I'm doing to have this high cholesterol. So when you do a genetic test and it comes out positive, you just know that you have a genetic form. It's not your fault. So it sometimes can be very reassuring to know that your cholesterol is genetic and not your fault. That also means that doctors know exactly what is wrong with your LDL receptors, as Simon just explained very well, and why they are not cleaning the cholesterol from your arteries properly. So the doctors can optimize treatment according to your LDL receptor activity. And of course, it's very, very important that you should not smoke and you should have a healthy lifestyle. It's even more important for people with FH to follow these recommendations. And you must know that you have a greater cardiovascular risk than anyone your age, even if they have the same cholesterol levels, like I showed you in the first presentation. And if you have a greater cardiovascular risk, you should get treatment as soon as possible so your cardiovascular risk can decrease. Like if you start treatment at 8, as the recommended in the guidelines, your chance to have a heart attack in adulthood is very low. It's the same as the rest of the population without FH. So it's really important to diagnose early and treat early. But if you know that you have definite FH, it also has implications at the family level. For once, it means that one of your parents also have FH. So if he or she have not been identified before, they should take the test and they should be treated as soon as possible. Also means that your siblings should be tested. They may have FH and need to start treatment as soon as possible to prevent cardiovascular diseases. Other first and second degree relatives should also be tested. Like I said, all families should be tested if they want, of course, but it has great advantages for cardiovascular prevention if everyone is tested and knows if they have FH or not. It's very important when you're diagnosed that you know that the next generation, so your children, they will be tested much earlier, and they're going to be tested, ideally around 5 years old, and that means that cardiovascular prevention can be achieved in those kids because they are going to be identified and treated since very early in life. And we know that if they are identified early in life, they are not going to develop cardiovascular diseases. And it's very good if the whole family can adopt the healthy lifestyles. Because that makes kind of life easier for a person with FH. The person with FH has some limitations on the diet, especially, and other lifestyles. And if the whole family adopt a healthy lifestyle, it makes life much easier for someone with FH. So I hope I was clear with these messages. But I'm very happy to take any questions, Emma, if you do have it.
Wonderful. Thank you, Mafalda, and thank you very much, Simon, as well. I found all of your presentations incredibly informative and very clear to understand as well. So thank you both. I certainly have quite a few questions, as I imagine Elsie has as well.
So I'll start off with some simple questions. So as somebody who lives with familial hypercholesterolemia, the more severe form, obviously variants play a very big role. But what if I have high cholesterol, I don't have heart disease in the family, there's no kind of reason to think that there is it still important to actually have it tested, have myself tested for FH, and why is the genetic part so important?
It's like I said, it's always very important because of the advantages of the early detection and the early identification is to start treatment as early as possible. That is what is going to change the kind of the story of the disease, because if you're treated at 8, like the recommended guidelines, you don't develop heart diseases when you're an adult. So now we have about 30% of adults having cardiovascular diseases when you have FH, heterozygous FH, we're talking about heterozygous FH. Homozygous FH is a much more severe form of FH. So if you're treated since you're very young, you're not going to develop a heart disease, and that's actually very important in families that already have heart disease. Like a dad that died prematurely at 30 or 40. It's a huge thing for a family. And knowing that you can prevent that in the future generations is really important. I understand your question. Like, if you don't have heart disease in the family, it's quite difficult to understand why you should be tested and why you should be treated from such early age. But the things like people are very different, even with the same variant. It depends a lot on your lifestyles as well. Maybe you don't have cardiovascular disease in your family because your father that has FH, for example, has a very healthy lifestyle. But maybe you start smoking and your diet just got much worse when you left home. And that is going to make, with your FH variant, is going to make you to develop heart diseases, and you're going to be the first in your family with a heart disease. So I think that the really important message here is early identification to prevent heart diseases in the future, and to actually know why you need to change your lifestyles. Everyone knows that they need to change your lifestyles, but if you know that you have a genetic condition that is going to predispose you to have heart diseases, much higher predisposition, maybe you think twice when you think about starting smoking and only eating fast food and things like that. So that's the whole message.
Thank you.
Thank you. I'd just like to intervene here as well, actually, because Mafalda, I totally agree with you about the importance of getting tested, even if you don't have heart disease in your family. So I have the common form of familial hypercholesterolemia, which is known as heterozygous familial hypercholesterolemia. Now, we didn't have any heart disease in my family at all that we were aware of. However, my mother then passed away from a heart attack, which is how I ended up being tested. So if you have high cholesterol, even if you don't have knowingly have heart disease in your family, it is super important to get tested. But Mafalda, another question for you on the same lines. I think there's quite a few countries that don't have access to genetic testing. So if somebody suspects that they have high cholesterol, or they potentially have heart disease in the family, what should they do to get diagnosed?
Yeah, it's really difficult when you don't have in your family. Of course, there's the doctors. There's lots of doctors that have collaborations all over the world. And for example, I perform genetic testing for different countries. So you can always, if you're lucky, you have a doctor with good connections that get you a genetic testing. But if not, that's why we have the clinical algorithms. You can the doctor can see if you have a high probability of having FH. If you have high cholesterol, and in your family, your father, your mother has high cholesterol. And then if you have kids, it's very important. The kids is a very, very important information in the family, because it's not normal for a kid to have high cholesterol. So if you're 30 something and you have a 8-year-old boy, and you test the boy, and the boy has high cholesterol as well. So that's a very strong evidence that you have FH. You have 3 generations with high cholesterol. You have a kid with high cholesterol. That's not normal. Although these days having children with high cholesterol, it's becoming more and more common, because like we all know about all the bad lifestyles that children are adopting. So always on the phone, no one is running and playing anymore. But it's not normal to have at least with such a high. We are talking about an LDL of 160 or above in a child. So maybe they have 130 or 40, but not 160. So 160 is really going for it for FH. So studying the family is really important. Like, for example, if someone asks me to study someone that has a borderline cholesterol, and I don't know they fulfill completely the clinical diagnosis, the first thing I ask, like, can I study more people from the same family? Can you send me blood samples? Can I determine the cholesterol from the cholesterol, the LDL, total cholesterol, triglycerides, the HDL, so the four most important lipid parameters. And if I'm able to study the family, I can have a look at the lipid profile and see if the family still has a high probability of being FH, and then we do the genetic testing, or if it's another lipid disorder, or if it's just environmental, like if you have very high triglycerides, it's usually not FH. FH is a very clean cut, a very clean lipid profile, is very high LDL. That doesn't mean that you cannot have a person or two with FH with high triglycerides as well. It just means that the person doesn't eat very well and probably drinks a little bit too much. But usually it's a very, very clean profile, high LDL, high total cholesterol, normal triglycerides. So if you don't have genetic testing, you have to go into the clinical and studying the whole family. That is what I would recommend. Study as many people from a family and see if it really runs in the family.
See the patterns.
Yeah.
Excellent. Thank you.
I have another question. This time I'm going to go for Simon. Could you say, so Mafalda explained that obviously the phenotype FH, I have to try and remember these names, is about different cholesterolemias, but you spoke about the different variants. Now, is it possible that you could have FH with one or two of these variants, or is it just that one of the variants would be there?
Yes, that's of course a very important and also interesting question. Emma just mentioned that she's heterozygous FH. So in this case, there is only one of, you have a double set of chromosomes, so only one of them is affected. And one intact allele is still present. But then, of course, there are more severe situations if both alleles would be affected and you don't have an intact allele that can compensate for that to a certain extent. And of course, we can have combinations. There can be a mutation in the LDL receptor, which comes along with a mutation in apolipoprotein B, which are called compound heterozygous mutations. So, and these are, of course, then more complicated settings in a way, and in most cases require more intensive treatment also later on.
And just to be very clear that these variants are genetic, whatever my lifestyle is won't make a difference to that specifically, but lifestyle will still have an impact on how maybe the cholesterol levels are done. But the actual variance is genetic and nothing that kind of comes out of nowhere.
Yes, and I think it's important to still know even that even though you have a genetic or might have a genetic predisposition, there is still something that you can do with your lifestyle and diet. As shown in the presentation before, if you have lower cellular cholesterol uptake, you will have more in your blood. But with your diet, you can really affect how much you can have in your blood from a starting perspective. To some extent, of course, there are other biological processes involved.
Can I jump in as well? What is important is that even if you have a genetic defect, let's say, your lifestyles are very important because you already have a high cardiovascular risk because you have a genetic defect. But if your lifestyles are all wrong, if you don't eat properly, if you don't exercise, you can worsen your phenotype. So that's why I was saying that maybe different people in the same family have different phenotypes. Some behave very well, they have perfect lifestyle, and the others, they don't care and they smoke and they eat fast food every day, and so it's really important that it's not like you have a genetic condition, you cannot do anything. No, you can't do a lot. You should take care of your health. If you have it, of course, you should take care of your health. If everyone should take care of their health. But if you have FH, you really have to take care, not smoke. It's really important. And that's why it's so important as well to identify in children, because it's much easier to teach a child from early age what to eat, not to smoke, and what is the danger of smoking if you have FH, than getting a 20-year-old. That's awful. That's the worst age of all of them. They're not going to do anything that you say. They are rebels at 20. I know, because I have 3 at home. So they're not going to do anything that you say. So if they are 5 or 6, they are diagnosed, then the whole family has a healthy lifestyle. The child grows in a healthy lifestyle, and it has to be explained that he has a genetic condition at some time in his life, and I think that will improve adherence to all the lifestyles and treatment as well. It's really important. That's another thing that we haven't talked about. It's really important that you take the medication every day. Your liver works every day. It doesn't work just one day a week or once a month. It's processing the LDL every day. So you have to take the medication every day, and from an early age, and you're free of cardiovascular disease. I think this is great. There's other diseases that you don't have so much knowledge, so many treatments, and this one you have a chance to prevent. So I think it's really important to talk about that.
Yeah.
Thank you, Mafalda. Oh, sorry, go on, Simon.
No, I mean, I just wanted to say I fully agree. So, yeah.
Yes, I do as well. And I found it really interesting, actually, Mafalda, going back to your first presentation, that with a demonstration of the plaque buildup for somebody that has got FH, obviously you see that building up from an early age, but then with the intervention of the correct medication and the lifestyle changes, an 8-year-old, for example, could go on and be free of cardiovascular disease for their entire life, which is superb. And you're absolutely right about making the lifestyle changes as you get older much harder. I mean, I've had I was brought up in a family with a healthy lifestyle, but even so, I didn't get diagnosed till I was 37, and by that point I did like my cake and my chocolate and everything else. And so trying to not that I ate a lot of it, but trying to reduce it is pretty hard. So the earlier the better, which then leads into the importance of cascade testing and early screening, so that other family members can also be supported. And that reminds me, actually, you also mentioned about the importance of testing second-degree relatives. So I just wanted to confirm, a second-degree relatives classified as sort of aunts, uncles, and cousins.
Yeah. That's it. So if you have FH, your mother or father will have FH, and so their brothers and sisters should be tested, and then their all the generations below that. So it's when it runs in the family, if it's a FH, it's a dominant disorder, or more scientifically, it's called a semi-dominant disorder. But that means that it will appear in every generation. So it's some families, they have three kids and the 3 have FH, but maybe another family only has actually 5 and only 1 or none of them. So it's every time you have a child, that child has a 50% chance of having a FH. So it's always you never know what will happen. But if it happens with you, it happens with your uncle and their children. So it's really important to study the whole family, and because that will allow this early detection. Because if you don't know you have high cholesterol, it doesn't hurt. It doesn't show in your face that you have high cholesterol. So you're not going to be tested. That's so easy as that. You're not going to be tested. Maybe you're going to be tested when you start working, and then there's some kind of working medicine that ask you for a checkup. But if not, if you have someone in the family that has been identified, everyone should do a lipid profile and then go from that. That's really, really important.
And maybe I can just add, in a way, what I think is really important. If there is a diagnosis for FH, it also means that it's very likely that the efficacy of the drugs will not be the same as for a person without FH. And it's also in a way that knowledge and even knowing the genetic variant is enabling a doctor, but also the person living with that genetic variant to say also, okay, now we have to monitor this more carefully in a way, and maybe not follow this up in a long time window, but do this really early, because we kind of expect that it's very likely that there is additional medication needed to reach to very low blood cholesterol levels very fast, and which is super important to reduce the cardiovascular risk. And I think that's something where this genetic information can be an additional stimulus in a way to get to faster and more efficacious treatment earlier on.
And so it's very important for the person living with FH to know their genetic variants, so that then they can get the precise medicine that they need, which targets their specific gene and the gene variant that they have.
Yeah, yes, and we know every day we are knowing more, and we are studying more these genes and these variants. So all the information that we are getting, from the experiments that I do, the experiments that Simon does, we are getting lots of information about these variants, and that information is going to be very, very important for the doctor to optimize the treatment. And you have to know your variant, because if you go to imagine you change countries or you change cities, and you need to take your report with you. Don't lose your report. Your report is really important for your care. I think that's a very strong message as well, because I have been asked 3 and 4 times for reports for the same person, because they keep losing, or the doctor loses. So it's important that it's like it's an important document. So keep it near to you, because if you change doctors, especially if you change doctors that don't know exactly which variant you have and if you have FH or not, they need to look at the report and take care from there.
I think those are all very important messages to take away. One, about making sure that we screen early and find individuals early, but also the cascade screening in reverse, where if there is another person in the family that gets tested, making sure that there's family members are informed and get tested. I think that'll be a big change. The changes in understanding the variants and how that'll in the future help with precision medicine. And definitely something we will touch on again, Mafalda, is about the reports, how important they are, how to read them and understand them, but also how to then use that to advocate with doctors who might not understand that it's not just kind of environmental, that actually there's other impacts on it. I think there's a big learning curve there for all of us, but thank you.
And on that note, I think, Elsie, unless you have any more questions, we probably ought to close, because we're a little bit over time. And I would just like to thank you, Mafalda, thank you, Simon, thank you, Elsie. And yes, I'm sure we'll have some more webinars soon, particularly on the topic of understanding your report and what to do with it.
Yeah.
Thank you, everyone.
Thank you.
Yeah, thanks. Great to be here.